Right, so I'm just going to go over the events of the cardiac cycle. Now, this is going to refer to slides 36. So you go to slide 36, the cardiac cycle, go through 37, 38, 39, 40, 41, 42, even 43. The easiest way to kind of discuss a cardiac cycle is with this single, very important slide. Now, when we're looking at this slide over here, understand that why it's so important is that it allows us to relate what happens in an ECG to what happens with the blood pressures, therefore muscle contraction time in the left ventricle, to when you eject blood and fill blood, and how that all relates to even heart sounds. So let's start at the very beginning here. When we're looking at this chart, the easiest way to do it is to go in sequence, starting at the top where we have the electrical conduction output, the ECG, and how that causes the mechanical stimulation where the muscles actually contract. As the muscles contract, it will create pressure. That's why you see this on one of the axes as just pressure. But the pressure is indicative of the muscle actually contracting. And again, if you look at the pressure gauge right here, it goes up to 120. So you can see that this graph right here on this part with pressure is solely the pressure of the left atrium and the left ventricle. Right now, you will see something similar to this for the right atrium and the right ventricle, and you'll see blips at the same time. But the big difference is on the right side, you don't have to go to 120. Remember, the right ventricular pressure normally is about 20 to 25 millimeters of mercury. So if we did see a graph of the right side, it would be very short, just up to here, and that's it. Not enough for us to really get into the details and discuss the cardiac cycle. With this graph, it shows that as it kind of prolongs and enlarges to 120, which we see on the left side of the heart only. Now, again, the pressure change here is indicative and is an indication of any kind of left ventricular contraction or left atrial contraction, as we see over here. Now we know that pressure is indicative of contraction. Now, as we start moving blood into the ventricles, you'll see this region of left ventricular volume increase. As we eject blood, you see the left ventricular volume decrease as well. So this volume increase or decrease is going to indicate whether blood is moving into the left ventricle or out of the left ventricle, or is just sitting there. There are times when blood is just sitting there, and those times usually are going to be pretty short in nature, and they're going to be in areas where we have isovolumetric contraction or isovolumetric relaxation, right? Now, the last part of this chart is our heart sound. Now, the cool thing is we can now relate first heart sound, the lub, and the second heart sound, the dub, and relate it to when we have contraction of the ventricles and when we have relaxation of the ventricles. Remember, heart sounds are due to the closure of valves and blood hitting those closed valves. So it indicates some kind of valvular closure. So let's start at the very beginning. We start at the very beginning, and I always like to start right here. We have just completed one round of ejection, right? So one round of the cardiac cycle. What happens then? The heart is at rest. So on an ECG, nothing happens. Now, because nothing happens in the ECG is telling us that there's no actual stimulation. It doesn't really mean nothing's happening. Something is happening at this point that we call passive ventricular filling time. During this region right here, notice the aortic pressure in red is still very elevated. Notice that the pressure of the left ventricle, solid black line right here, is close to zero. And the pressure in the left atrium is slightly higher than the pressure in the left ventricle. Meaning what? Left ventricular pressure is lower than left atrial pressure. It's a sign that the mitral valve is going to be opened up. Remember, High pressure wins. It always causes movement of blood, of air, of water from higher pressure regions to lower pressure region. So now there's higher pressure in the left atrium, lower in the left ventricle. Blood should be going from the left atrium, from the lungs. This oxygenated blood will then go into the left atrium, which then passive filling means that that blood from the left atrium passively now moves to the left ventricle. Now keep in mind, that's incredibly important, especially at rest. Now, if you have blood going from the left atrium to the left ventricle, we should see a change in the left ventricular volume right here. And at this point, right here, the left ventricular volume is at 55 milliliters right here. So there's very little blood in the left ventricle. As we have passive filling, blood from the left atrium passively moves through the open mitral valve into the left ventricle where there's lower pressure. When that happens, you should see an increase in blood volume from passive filling. Perfect. We see it right here. Now, when passive filling time is about to end, we see at the very top right here, a P wave. The P wave is a sign that the SA node has fired. As the SA node fires, the P wave is the electrical depolarization of the atrial muscles. And what we see then is halfway through the P wave, I'm going to switch and go right at the halfway point at the very start of the graph. Halfway through the P wave, the left atrial pressure in blue starts to increase. It doesn't increase at the very start of the P wave. See that? The left atrial pressure is pretty low right here. It's about 8 to 10 millimeters of mercury. But once we're halfway through the P wave, then we start seeing that increase, right? Remember, you have to depolarize. Once you depolarize the muscle, you need the calcium release. That takes a little time. You need then calcium to bind to troponin to move tropomyosin. That's why there's a lag between when you have electrical stimulation, the start of the P wave, and when you mechanically see the change in pressure in the left atrium, right? And again, the change in pressure in the left atrium is a sign of the left atrial muscles contracting. As it's contracting, the left atrium is going to eject any remnant amount of blood that's still in the left atrium. Remember, about 80% of that blood passively filled from the left atrium to the left ventricle. So at rest, there's still maybe 15 to 20% of that blood still resting on the left atrium. And with the P wave and with the contraction of the left atrium, we're going to eject that 15 to 20% of the remaining blood in the left atrium into the left ventricle. And that's what we see here. As we have this active ventricular filling phase, that active ventricular filling phase is caused by the SA node firing, then the atria is depolarizing in response to the SA node. In response, then halfway through the atrial depolarization, which is a sign that we see with the P wave, halfway through, we start the contraction of the atrial muscles, the left atrial muscles. As it contracts, it ejects that 15 to 20% that remained in the atrium into the left ventricle. That's why we see a slight increase. Now, again, right, passive filling causes us to go from minus 55 to about 105 right here. The remaining 20 millimeters of mercury, right, of blood, the remaining 20 milliliters of blood is going to be moved from the left atrium to the left ventricle by way of that active ventricular filling time right here. So now we have topped off our blood volume in the left ventricle. We're at 125. What happens then? If we look at the P wave right here, and then the next waveform we see is a QRS. The QRS is a sign of ventricular depolarization. So we have this huge QRS complex right here, halfway through in the R phase. What we're going to then do is we've stimulated the left ventricle, and now it's going to start to contract. As it starts to contract, remember, it's already filled up with all the blood it can, right? So at the very start of our contraction of the ventricle, the contraction of the ventricle is called ventricular systole or just systole. So at the start of systole, the left ventricular pressure is very low. Again, maybe 8 to 10 millimeters of mercury, very low. But as soon as a QRS wave is seen, it's a sign that the ventricles have started to depolarize. So now, halfway through, it's going to start to contract. We know it's going to start to contract because we can measure it as a change in pressure. It goes from 8 to 10 millimeters immediately, right? It goes right up to 80, right? Why? It's because your ventricular muscles are very strong. As soon as they start to contract, the left ventricular muscles gain a lot of pressure almost at once. At this point, though, we're in a period of isovolumetric contraction. Since the left ventricle is contracting with a lot of force and a lot of pressure, the last thing we want to do is have that left ventricle contract from the apex. And as it contracts from the apex upwards, well, if we don't close that AV valve between the left atrium and the left ventricle, if we don't close that mitral valve, blood is going to go from the left ventricle backwards into the left atrium. That's not good. So we need to close that valve. And one of the first things we do when we contract the left ventricle and even the right ventricle is we create pressure differences. Now, if you take a look right here, right, the left atrial pressure in light blue and the left ventricular pressure kind of mirrored each other. As left atrial pressure goes up, left ventricular pressure goes up slightly as well. At this point, it's going to bifurcate. It's going to flip. It's going to switch a little bit, right? Only the left ventricular pressure goes up at this point. Why? Because only the left ventricle in this chart is going to see an increase in contraction. As it contracts, it creates pressure. To prevent backflow of blood back from the left ventricle back into the left atrium, we close that mitral valve. Closure of valves causes heart sound. So if we close this valve right at the very start of our period of isovolumetric contraction, that period of isovolumetric contraction starts halfway through our QRS complex, is a sign that we are in active ventricular systole. To prevent backflow, the mitral valve closes. Closure of valves causes heart sound. Perfect. That's where we start hearing our first heart sound. Now, keep in mind, right, that first heart sound now tells us that we are at the start of systole. Right? Now, we're not going to call atrial systole. When we discuss systole, we are going to know that when any doctor discuss systole, we're talking about ventricular systole. When we talk about diastole, we're talking about ventricular diastole. The atria, right, we don't really refer to it as that because their contraction just isn't very strong, just isn't as important. People can live even if the atria are not contracting efficiently, if they're in AFib, right? People can't live when they're in VFib. So ventricular contraction, ventricular relaxation is much more important. So the first heart sound tells us that we are at the very start of systole. The left ventricular pressure then exceeds the pressure in the left atrium. You've closed a mitral valve, but your aortic valve pressure is very high. That aortic valve pressure in red, right, occurs because of afterload. There's a little bit of blood sitting on top of that aortic valve from the previous contraction. From the previous contraction, you ejected some blood upwards at the very end of that ventricular contraction. because at the very end of that contraction, the blood you ejected very lower in pressure than the blood in the middle, right? In other words, if I'm in mid-systole right here, the blood I ejected up is pressurized to 120. If I'm at the very end of systole, the blood that I ejected up is 24% less pressurized, is at 100. So there's not enough forward pressure to eject that last amount of blood out into the aorta and then move it through the aorta. Instead, what happens is this, right? You've ejected blood out, the aorta, being a blood vessel, is stretched out. The aorta has a lot of elastic tissue, very similar to a rubber band. What happens then? As you stretch it out, the aorta wants to recoil, just like a rubber band that you have stretched out. So as you stretch out the aorta, at first, the pressure is so large you can force blood forward. But as the pressure drops in the left ventricle, what's going to happen? Blood is going to move backwards because the recoil of the aorta causes the last remaining amount of blood at the very end of systole. That last amount of blood you pushed out no longer has the same pressure. So then there's more pressure in the aorta than in the blood being moved from the ventricle. Blood then from the aorta going to recoil back towards the aortic valve. That blood then sits on top of the aortic valve, creating a pressure that the left ventricle must overcome just to open the aortic valve. Normally, the blood sitting on top of the aorta exerts a pressure of 80 millimeters of mercury. That means just to open the aortic valve, we need to be greater than 81 millimeters of mercury. If we create pressure from the ventricle and the pressure in the ventricle is 81 millimeters of mercury, all we can do is open the aortic valve. That's it, right? If it doesn't go beyond 81 millimeters of mercury, no blood will get pushed into the aorta. That's why our blood pressure exceeds 81 millimeters. It goes to 120, right? The first 80 millimeters of mercury of pressure, the very only the purpose of that is to create pressure, right? This is a period we call a period of isovolumetric contraction. At this phase, in the dark blue, this period of isovolumetric contraction is a time when all four valves in the heart are closed. So on the left side, we close the mitral valve at the very start of systole. The aortic valve was closed from the last cycle of contraction. That hadn't opened up again. So at that point, we haven't opened up the aortic valve. That's closed. Mitral valve is closed. On the right side, the tricuspid valve is closed, as well as the pulmonic valve is closed. All four valves at this point are all closed up. All we're doing at this point is building up pressure to open the aortic valve on the left side. We're building up pressure to open the pulmonic valve on the right side. Again, right, since nothing's moving, all four valves are closed. Should we see any change in the amount of blood that we see in the left ventricle? No, it stays the same, 125. No blood has moved in or out. Again, isovolumetric means no blood movement. Eventually, though, the left ventricle starts to contract and keeps on contracting with more and more force, creating more and more pressure. So as it does this, the pressure in the left ventricle now exceeds the pressure in the aorta. When that happens, you're going to start to open up the aortic valve. As you open up the aortic valve, should you hear heart sound? No, right? Heart sounds only caused by closure of the valves. The only time you should hear a heart sound when you open the valve is when you have a heart murmur of some form. All right. So what do we do then? At this point, all we've done is open the aortic valve. At this point, we're still in that long plateau phase that we talked about in action potentials in the cardiac muscle, right? So you're prolonging this contraction phase, sustaining the contraction, exceeding 80 millimeters of mercury. You go to 81 in the left ventricle and you open the aortic valve, and then I keep contracting. As I keep contracting the left ventricle, I keep ejecting blood from the ventricle now past that open aortic valve into the aorta. We call this period in light blue the ejection period or the ejection phase. This ejection phase occurs when we ejecting blood from the left ventricle to the aorta. Now, because the blood from the left ventricle goes directly in the aorta, you'll see that the aortic pressure in red mirrors the left ventricular pressure in solid black. So eventually you force and eject all that blood out from the left ventricle into the aorta. If we're ejecting blood out, we should see a change in blood volume. And that's what we see here. During time of ejection, there's a drop in the blood volume as you eject blood from the left ventricle directly into the aorta. There's a drop from 125 to 55. 70 milliliters of blood is then ejected. We call that ejected amount of blood from this to this. We call that our stroke volume. So normally, in a normal, perfectly healthy person, we start off with an end diastolic volume of 125. That's how much is in the left ventricle right before systole. Then we eject only 70 milliliters. So if you take a look at that, right, we're barely over 50%. So 70 divided by 125, we're at 56% ejection fraction, right? Meaning that the amount that's ejected, our stroke volume of 70, divided by how much we had at the very start, 125. 70 divided by 125, 56%. And again, when your heart is at rest, right, anything higher than 52 to 56% is considered a pretty healthy heart, right? You're ejecting more than what's left over. Now, what happens as we have this period of ejection? During the period of ejection, blood from the lungs starts to come back into the left atrium. Now, also, we start seeing the T wave. The T wave is a sign of ventricular diastole, ventricular relaxation. And what do we see? Halfway through the T wave right here, some of the ventricular muscles are going to start to repolarize and relax. As it starts to repolarize and relax, right, now some of the ventricular muscles are going to relax, causing a drop in blood pressure. As there's a drop in blood pressure, well, even though it's dropping, it's still greater than the blood pressure in the aorta. What happens? You're still ejecting blood. Eventually, though, right, the recoil of the aorta creates a pressure that exceeds the pressure of the relaxing left ventricular muscle. So then the recoil pressure from the aorta, the resistance pressure in the aorta, just like a rubber band, the more you stretch it, the more it wants to recoil. Now you've ejected a lot of blood into the aorta under a great amount of pressure. You've stretched the aorta a tremendous amount. It wants to recoil now. As it does so, all right, that the recoil doesn't occur at first because you can still maintain higher pressure in the left ventricle. So then you keep ejecting blood outwards. But eventually, as more and more left ventricular cardiac muscles relax, the pressure drops tremendously from 120 till about 90. As it hits about 90 right here, now the recoil pressure in the aorta is greater than the pressure in the left ventricle. Blood, then, that you just ejected at the very end, no longer has that forward thrusting pressure. Instead, the aorta recoils, causing blood to move backwards. As the aorta causes blood to move back towards the aortic valve, that blood that moves back causes closure of the aortic valve. As the aortic valve closes right here, we should hear a second heart sound. That second heart sound is then a sign that we have started diastole. Again, first heart sound, indicative that of the start of systole. Second heart sound is a closure of the aortic valve, is a sign that we have started diastole, right? It's a sign that the pressure has dropped significantly. So then it's a sign that the pressure drop means ventricular muscles relaxing, right? At that point, more recoil pressure in the aorta. The left ventricle cannot maintain that pressure anymore because more and more of the muscles start to relax. Now there's greater recoil pressure in the aorta than pressure in the left ventricular muscles. What happens? Blood moves back from the aorta towards the aortic valve, closes up the aortic valve, causing that second heart sound. At this point, all four valves are closed again. And all we're doing now is entering a period of isovolumetric relaxation. So in the period where there's isovolumetric contraction, isovolumetric relaxation, there's no blood flow going in or out of the ventricles, right? Usually that means all four valves are closed again. Here, the aortic valve just closed up on the left side, and on the right side, the pulmonic valve just closed up as well. Those two should mirror each other. We closed the mitral and the tricuspid valve at the very start. It never reopened yet. So at that point, all four valves are closed. And all we then have is the left ventricular muscles, all of them start to fully relax. When that happens, the pressure drops in the left ventricle to 0 again. We should see that. Remember, right? All four valves are closed. So should we see any blood moving in or out? No, right? The blood stays static right here at 55 milliliters right here, right? Then what happens? Remember, blood halfway at the start of the ejection phase, blood from the lungs starts moving into the left atrium. And now as it moves in, it creates a little bit of pressure in the left atrium. As the pressure starts to increase in the left atrium, the pressure in the left ventricle drops to 0. The left atrial pressure now exceeds left ventricular pressure. As the left atrial pressure in this dotted blue line exceeds the left ventricular pressure in the black line, right? Now we have opening of the mitral valve, right? Again, the greater the pressure difference. So as the left atrial pressure exceeds the left ventricular pressure, that valve that was closed over here now opens up over here. And it's a sign that we are now starting a new cycle, right? Now we have passive filling again as blood goes from the left atrium past the opened mitral valve into the now fully relaxed left ventricle. As blood goes from the left atrium to the fully relaxed left ventricle, we should see a little bit of a change in the blood volume. And that's what we see right here. Again, keep in mind, all of these are related to each other. As there's a change right here, where now there's left a greater amount of pressure in the left atrium than in the left ventricle, it forces that mitral valve to open up. As the mitral valve opens up, blood is going to go from the left atrium past the open mitral valve into the left ventricle, and now the left ventricular blood volume should increase. And this is a passive filling time right here. Now, the important thing is this: at rest, when your heart rate is at 60 beats per minute, this passive filling is incredibly important. It accounts for about 85% of our total blood volume movement into the left ventricle. Now, what happens though, right? Now, keep in mind, all right, if a heart rate is low, 16 beats per minute, at rest, you have a prolonged passive filling time. What happens when you work out? When you work out, instead of 1 beat every second for a minute, 60 beats per minute, you're going to have 2.5 beats per second. And your heart rate will be between 120 and 150. Your passive filling time is going to greatly shorten. When that happens, then our active filling is going to be much more important, right? Because our active filling now accounts for a lot. And because we have increased the heart rate, our passive filling time is severely shortened, right? When that happens, instead of having this prolonged passive filling, as soon as we recover, we have another contraction. When that happens, we are very, 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 at that point, dependent on active filling. Again, during normal, quiet, resting heart rate, all we need is passive filling because you have such a long time between heartbeats. But when you're working out, that passive filling time is completely shortened up. At that point, then we are dependent on atrial contraction and active filling. That's the time when we need that active filling. Perfect.